Picture this for a second. You're standing right in the middle of a frantic emergency room. Monitors are blaring, alarms are ringing off the hook, and a patient has just been rolled through the double doors. Their blood pressure is plummeting, their heart is absolutely racing, and honestly, the clinical picture is just an absolute blur. In an environment like this, you know you really don't have hours to sit back and ponder textbook theories. You've got minutes, sometimes literally seconds, to find the true signal buried beneath a mountain of physiological noise. Welcome to today's Explainer, where we're going to break down the intense, high-stakes decisions that frontline clinicians face every single day.
Okay, let's dive right into this. The harsh reality of acute medicine is that a lot of life-threatening conditions look practically identical on the surface, but they actually demand totally opposite treatments. If you make the right call, the patient survives. But make the wrong call, you might actually accelerate a fatal collapse. So today, we're decoding exactly how medical professionals differentiate between these identical-looking crises, using rapid-fire diagnostics and some seriously deep physiological understanding.
Section 1. Shock. Anaphylactic versus septic. So, here's a scenario that instantly spikes the adrenaline of absolutely anyone in the room. Shock. Your patient's vital signs are crashing hard. Imagine they're profoundly hypotensive, meaning their blood pressure is bottomed out, and their heart is beating out of their chest just trying to compensate. You know right away they're in what's called distributive shock, where the blood vessels have massively dilated. But here is the absolutely crucial question. Is this being caused by a severe allergic reaction, anaphylaxis, or is it caused by a raging system-wide infection known as sepsis?
When we break down the underlying mechanisms, they are starkly different. On one hand, anaphylaxis is basically an immune system explosion. It's an IgE-mediated hypersensitivity reaction, an antigen cross-links with antibodies on mast cells, triggering this massive, super-fast release of histamine. And that causes sudden vasodilation and acute bronchoconstriction, so the airways literally clamp down. On the other hand, we have sepsis. Now, this isn't some fast allergic trigger, it's a microbial invasion that sparks a systemic inflammatory response syndrome, or SIRS for short. The patient's skin might actually feel warm early on because of the vasodilation. So while both of these conditions tank the body's vascular resistance, their root causes are radically different.
Now, while the immunology is kind of abstract, the physical evidence usually isn't. You can't exactly see an IgE antibody floating around, but you can look for definitive physical signals. Think urticaria, which most of us just call hives, and sometimes this really deep swelling known as angioedema. If you've got a patient with profound hypotension paired with these red raised skin lesions and they're wheezing as they struggle for air, well, you found your signal. It's anaphylaxis. And once you know that, the most crucial thing is execution. You absolutely cannot hesitate here. The definitive first-line treatment is intramuscular epinephrine. It is literally the only drug that immediately reverses that vasodilation and the airway swelling. Any delay getting epi on board directly increases the risk of death. Once that's done, you follow up with isotonic intravenous fluids, like 0.9% saline, to restore their circulating volume, and then hit them with antihistamines and glucocorticoids to calm down that secondary immune cascade.
Section 2. Tracing the hypermetabolic crisis.
Let's shift gears and transition from the chaotic ER to the highly controlled environment of the operating theater. We're looking at a catastrophic failure in temperature regulation. Typically, a post-op fever takes days to develop, but an immediate soaring fever right after or even during surgery, that presents a brutal 50-50 dilemma for the clinical team. You reflexively wonder, is this intraoperative septic shock from some hidden, dirty surgical field, or is it a fundamental cellular failure? Either way, the clock is ticking loudly.
If the clinical audit points away from sepsis, it's malignant hyperthermia, or MH. Actually, scratch that. Calling it just a fever doesn't do it justice. It's a hypermetabolic defect driven by uncontrolled calcium release via mutated ryanodine receptors, RIYR1. It gets triggered directly by volatile anesthetic gases or the paralytic succinylcholine. So how do you spot the true signal here? You look for the deciding vector, masseter muscle rigidity. Basically, their jaw rigidly clamps shut during intubation. Combine that with an explosive respiratory acidosis where end-tidal CO2 soars way past 70 millimeters of mercury, and you know their cellular metabolism is stuck in absolute overdrive.
The absolute dumbest mistake you can make right here is just slowing down the case or giving basic antipyretics like Tylenol to try and lower the temperature. No way. You must act instantly to break the cascade. First, you immediately abort the triggering agent, flush the anesthesia machine out, and hyperventilate the patient with 100% oxygen. Second, You slam them with intravenous dantrolene to directly block that ryanodine channel and stop the massive calcium dump. And third, you initiate active cooling measures with ice. You're physically cooling the patient on the outside while the dantrolene works chemically on the inside.
Section 3. Toxidromes. Reversing the damage.
When a patient comes in poisoned, the clinical signs they present with form a specific pattern called a toxidrome. Identifying the exact chemical trap is the only way to reverse the damage. And I want to highlight a classic, honestly deadly trap in toxicology. Say a patient comes in with a racing heart and sky-high blood pressure. Your very first instinct might be, hey, let's give a beta blocker to slow that heart down. But if that patient is suffering from cocaine toxicity, giving a pure beta blocker is a catastrophic mistake.
This brilliantly illustrates why understanding the underlying mechanism is so vital. Cocaine blocks the reuptake of neurotransmitters, causing a massive surge in sympathetic tone, which is why the heart races. But our sympathetic nervous system has two main types of receptors, alpha and beta. If you give a pure beta blocker, you shut down the receptors that help vasodilate, leaving the alpha receptors, which constrict blood vessels, completely unopposed. The result? A deadly, skyrocketing hypertensive crisis. The correct rescue isn't a beta blocker. It's actually benzodiazepines to calm the central nervous system down, along with supportive care.
Let's compare two other incredibly common yet completely different overdoses to see how these patterns play out. Take opioids. The telltale signs here are meiosis, those pinpoint constricted pupils, along with bradycardia and a profoundly depressed respiratory rate. They literally just stop breathing. On the flip side, we have tricyclic antidepressants, or TCAs. With TCAs, the pupils are myodratic, meaning widely dilated. They present with an anticholinergic toxidrome. Think dry mouth, flushed skin, urinary retention. And most dangerously, you'll see a wide QRS complex on their EKG, which is a massive red flag for potentially lethal heart arrhythmia. Once you identify the toxidrome, you reach for the specific chemical key to unlock the trap. Here's a quick, rapid-fire cheat sheet for you. For acetaminophen overdose, which destroys the liver by depleting its antioxidant stores, you use N-acetylcysteine to replenish them. For opioids, you use naloxone. It's an antagonist that violently knocks the opioid right off the brain's receptors to instantly restore breathing. And for those dangerous TCAs, and surprisingly for salicylates, which is just aspirin, the antidote is sodium bicarbonate. It alkalinizes the blood and urine to protect the heart and help flush those toxins right out of the system.
Section 4. The acid-base anchor.
But what happens when the physical symptoms blur? What if the patient is unconscious and the physical exam is just totally confusing? That's when we shift to our final diagnostic tool, the patient's blood. Clinicians use a highly structured cognitive pathway to anchor their diagnosis in pure biochemical data. It's called the Placo pathway. First, P. Check the arterial pH. Is the blood acidic or alkaline? Second, L. Gather the labs, specifically the arterial blood gas and basic metabolic panel. Third, A. Calculate the anion gap to look for hidden acids in the blood. And here's a pro tip. You absolutely must correct that gap for the patient's albumin levels. Fourth, C. Check for compensation. Is the body breathing faster or slower to try and fix the pH? And finally, O. Look for other processes and check osmolality. This step-by-step logic just cuts right through the clinical noise.
And you really need a pathway like this because toxidromes are incredibly dynamic. Take salicylate, or aspirin, poisoning again. It doesn't just do one thing and stop. Early on, it stimulates the respiratory center in the brain, causing the patient to hyperventilate. They blow off carbon dioxide, resulting in an early respiratory alkalosis. But as time passes, the toxin actually decouples cellular respiration, flooding the body with lactic acid and other acids. That results in a delayed severe anion gap metabolic acidosis. The blood literally tells the story of the poison as it unfolds over time.
Ultimately, medicine at this level isn't just about memorizing a static list of symptoms. It's about deeply understanding the physiological mechanics beneath the surface. It's about knowing exactly why a beta blocker is fatal in one scenario and life-saving in another. It's about letting the biochemistry cut through the sheer chaos of the emergency room. So the next time you hear about a high-stakes medical save, remember the incredible precision and structured thinking it took to get there. When the alarms sound and the symptoms blur, will you see the signal or just the noise? Thanks for learning with us today on This Explainer, and we'll catch you next time. Keep looking for the signal.